Assalamu alaikum. I'm Dr. Sabrina, resident anesthesiology, Dhaka Medical College Hospital. My topic is management of snake bite. I choose this topic because the annual mortality rate from snake bite in Bangladesh is around 6,000. The common vipers in Bangladesh are green pit vipers and the Russell's vipers. Here the important information is 50% of bites by Russell vipers do not result any symptoms or signs of envenoming. And here important thing is the victim develops some feature due to anxiety or apprehension in case of bite by venoms as well as non-venomous snake. Then when a patient came to emergency department, first we took the history from the patient site of the bite, circumstance of bite and time of bite, and also how did it happen, green pit bursts in face and limbs in cobra, any site grade, forearm, sea snakes, nighttime bite, especially in crate bite. Then we go for some symptoms some non-specific symptoms are headache, nausea, vomiting, abdominal pain, loss of consciousness, difficulty in vision and convulsion also. Some neurological symptoms also develop like muscle paralysis, difficulty in moving jaw, tongue, eye, ptosis, weakness of the neck muscle, difficulty in swallowing, dribbling of saliva, nasal regurgitation, nasal voice, difficulty in respiration and extreme generalized weakness. Then we go for some hematological symptom. We see that spontaneous bleeding from gum, vomiting of blood, coughing out of blood, passage of blood per urethra and persistent bleeding from bite side, etc. Then we also take the history of pre-hospital treatment, like any home treatment, treatment from traditional healers or OJA, and application of tourniquet, history of immunization against tetanus, and treatment by initial attending physicians. Simultaneously, we started physical examination of the patient. First, we rapid clinical assessment, especially the vitals like pulse, BP, respiration and temperature. Then we also go for systemic signs of envenoming, like chronology of onset and progression of the signs. We also take history about the neurotoxic sign like ptosis, diplopia, nasal voice, facial paralysis and paralysis of the chest muscle, broken neck sign, etc. Sign of hematological abnormality like persistent bleeding from bite site, multiple bruise, hemorrhagic blister, hemoptysis, hematuria and epistaxis also. Some renal failure, signs of some renal failure like scanty or no micturition, dark urine, clinical uremic syndrome like nausea, vomiting, hiccup, fit or drowsiness, coma, etc. Sign of myotoxicity, muscle tenderness, weakness, respiratory failure, black urine and renal failure. Sign of local envenoming, swelling, tenderness, bleeding, ulceration, necrosis, local lymph node enlargement. Then we try to identify the snake by photograph or model or preserved specimen, and also by local examination like classic fang and teeth mark rarely occur and if present indicate venomous snake bite. Scratch usually indicate non-venomous snake bite but may rarely found in crate bite. Snake may bite through clothing. Keep it in mind. Identification of a snake, the offending snake from fang mark is impossible. Then we go for local swelling and tissue damage, first sign of envenoming. Exception creates sometimes in cobra, blisters, necrosis. We also go for other systemic examination. Simultaneously, we send some investigation to the lab coagulation test. This is 20-minute whole blood coagulation test, ECG, complete blood count, blood urea, serum creatinine, urine RME and naked eye examination of the urine, activated partial thromboplastic time, prothrombin time, creatinine phosphokinase, ELISA and blood grouping and RS typing also. Then simultaneously we started management of the snake bite. First we reassured the patient immobilization of the limb, and this is not applicable in case of viper bites. Harmful thing not recommended, like tight tourniquets, incision at the bite site, local suction, cauterization by chemicals, applications of materials, ingestion of herbal products to induce vomiting, and unnecessary delaying. This is the picture, shows the situation after improper management, like tight tourniquet, etc. Then we started treatment in hospital. First, rapid clinical assessment and resuscitation by AVC management. Detailing clinical assessment by local, neurological or hematological examination and identification of species. Broad snake life, dead or description, photographs and 20-minute WBC count, and also by syndromic approach. We give the treatment initially, started antibiotic, tetanus prophylaxis, antivenom, and antivenom treatment indicated for neurotoxic sign, rapid extension of the swelling, acute kidney injury in case of cardiovascular abnormalities, bleeding abnormalities, and hemoglobinuria or myoglobinuria not due to sea snake. Then anti-snake venom therapy. Dose of anti-snake venom therapy. Each dose consists of 10 vial of polyvalent antivenom irrespective of age and sex of the victim. Time and administration of anti-snake venom therapy. Each vial is diluted with 10 ml of distilled water, and 10 such vials is further diluted or mixed with 100 ml of fluid. Then it is administered with intravenous infusion within 40 to 60 minutes. Observation and monitoring also necessary in case of antivenom treatment. Continuous observation and frequent monitoring of vital signs should be ensured during antivenom therapy and few hours after its completion. Careful clinical assessment for appearance of the signs and symptoms of antivenom reaction should be performed. This is the picture of the polyvalent anti-snake venom. This is active agonist, Indian cobra, common krait, Russell vipers, and saw-scalded vipers. There are three type of reaction we saw in case of antivenom reaction, like early anaphylaxis, pyrogenic reaction, late reaction, like serum sickness type of reaction. And additional treatment we give like injection atropine, injection neostigmine, and we give the respiratory support in case of respiratory failure. We transfuse blood for patient with coagulopathy. We introduce a endotracheal tube in case of respiratory failure. Now, so the criteria for repeating the initial dose of antivenom. This is in case of persisting or deteriorating signs of the systemic antivenom. Example, if no improvement or deterioration of neurotoxic features within 1 to 2 hours of completion of the antivenom therapy, and persistence or recurrence of the blood-thin coagulopathy after 6 hours of the antivenom treatment. Which drug is not recommended in case of snake bite? This is antihistamine except for antivenom reaction. We use this antihistamine in case of only when reaction is occurred by giving antivenom. Then corticosteroid except antivenom reaction, sedative, antifibrinolytic agent, heparin, and traditional medicines from OJAS. Then we take care of the beaten part by elevation of the limb with rest, simple washing with the antiseptic solution, broad spectrum antibiotic, especially when there is feature of contamination or multiple incisions. In case of local necrosis and gangrene, we give the broad spectrum antibiotic, and surgical debridement and split thickness skin grafting is indicated. Then after treatment, we give the rehabilitation like physiotherapy and reconstructive surgery also. What should we do when no antivenom is available? This is the very important thing, because in case of sometimes antivenom is not available. In this case, if neurotoxic sign is developed, assisted ventilation via ambu bag or mechanical ventilation is applied, and injection atropine and neostigmine is used. In case of hematological abnormality, strict bed rest to avoid even minor trauma. IM injection must be avoided, and fresh whole blood or fresh frozen plasma transfusion should be given. My presentation is completed. Any questions? Thank you.